Hi everyone, sorry about that. I'm not sure what happened there. But good evening, and thank you again for joining us for the Enhancing Allied Health Practice, Measuring Patient Improvement and Pulmonary Rehabilitation Options, proudly supported by Central and Eastern Sydney Allied Health Network. My name is Lauren Thomas and I'm CPD Program Officer at Central and Eastern Sydney PHN. I would firstly like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respect to elders past, present and emerging. I also extend that respect to Aboriginal and Torres Strait Islander peoples who might be joining us tonight. So at the end of the webinar, we'll have an evaluation survey that will be available from the chat box and also will be sent out to you in an email. We really appreciate your feedback. Please complete this to allow us to issue the certificates of attendance. For any GPs who might be joining us tonight, you'll need to self-report this activity to your relevant CPD home. If you have any questions for our speakers tonight, please pop them into the Q&A box and they'll be answered at the end of the presentations, and we'll endeavour to get to as many questions as we can. I'd like to just draw your attention quickly to some upcoming events from CESAHN. If you'd like to register, please go to our CESAHN website. We've also got some CPR workshop dates that are available for the rest of the year. I would now like to introduce our facilitator for tonight, John Petrozzi, who is the chair of the Central and Eastern Sydney Allied Health Network. Thank you, John.
Thanks, Lauren. Thanks very much. Just want to first actually say thanks to Lauren and her CPD team at CESAHN for organising tonight's webinar. And importantly, I'd like to thank attendees who are listening on tonight on this important topic of quantifying patient care, as well as pulmonary care for patients in primary care. And our first speaker is Dr. Rav Fernando. She's CEO and co-founder of QuantCare. Dr. Rav is a psychological scientist with a PhD in psychology from the University of Melbourne. Her research specialises in attitudes and behavioural change and understanding the fundamental question of why do people do what they do. Having experienced chronic pain and undergoing intensive treatment, Rav was inspired to use her research and data analysis skills to pick up potential at-risk patients early in the treatment journey. This resulted in QuantCare, which is a platform to help healthcare providers use the power of data to practice patient-centred care and improve their business at the same time in primary care settings. Her mission is to bring the patient voice into clinical practice and help healthcare providers use data for good. I'm looking forward to tonight's presentation from Rav. Thanks, Dr. Rav. Over to you.
Thanks so much, John, and thanks, Lauren, for the introduction as well. I'll just start sharing my screen now. Let me know once you can see it.
Yeah,
Great.
We can see that. Thank you, Rav.
Perfect. Thanks so much, John. And thank you for the introduction as well. Great to be here tonight with all of you. I'll try to keep this short and sweet. I know a lot of you are probably tired with work and also everything to come for the rest of the night as well. So what I'd like to do today is just talk a little bit about patient-centered care and putting patient-centered care into practice using the concept of patient-reported outcome and experience measures and leveraging digital health technologies. So a lot of things I talk about will be technology agnostic in terms of PROMs and PREM selection. And then the second half of what I will talk about is how we can actually leverage digital health to implement some of these in practice. So in terms of agenda, what I'd like to start with is an understanding of why do patients typically drop out of their treatment program, especially from a biopsychosocial perspective. I'll then move on to understanding how PROMs and PREMs can actually be used to assess these risk factors that may predict why patients drop out. And then finally, we'll look at how can we leverage digital health for potentially implementing PROMs and PREMs in practice. So we know that improving patient treatment adherence is increasingly challenging. And some of the research from the musculoskeletal health space tells us that up to 50% of patients can fail to attend consecutive appointments. And this is because patients have complex needs, right? Recovery is subjective, it's influenced by so many different factors. obvious ones being more biological factors, such as someone's injury or their condition, but there could be other underlying factors, the ones that might be a little less obvious, such as social and psychological factors, which might be subjective, or what we might assess during subjective assessment, during the assessment phase. A couple of years back, we actually did a survey with 125 allied health clinicians, mostly in the musculoskeletal health space, but ranging from physio, podiatry, chiro, myotherapy, speech pathology, and psychology. And across a lot of these clinicians, we got a response that 94% of these clinicians said that assessing these subjective factors, so these social psychological factors, is very important, but it's extremely difficult to do this in a time-poor clinical environment. And a lot of the clients that we have at QuantCare, we've had lots of clinicians that have questions related to patient adherence that are not always easy to answer. So some example questions could be, does my patient actually perceive an improvement over time? So maybe their objective assessment is revealing that they're improving, but does the patient themselves believe that they're changing and they're improving over time? Are patients happy with their appointments, particularly patients that might be a little less verbal, or patients that might have English as a second language, or from a minority background? It might be harder to gauge if patients are actually happy with their appointments as they come through. Are patients at risk of completing their treatment program? That's a big question that we get is, are there ways for us to proactively understand whether a patient is at risk of dropping out or not completing their patient program? Have they achieved their goals, particularly from their point of view? At what point might we need to refer patients? Do I need to refer them? When should I refer them? And this very important question that we get a lot of the time is, why is my patient canceling or not attending their appointments? And sometimes the reasons are obvious and sometimes they're not. So we have data from just over 20,000 patients now. And from that data, we can see that there's a high risk of treatment adherence in particular patient groups. And just overall across the patient base, we see that up to 75% of patients can have at least one flag, or what I call a red flag, that could potentially predict whether they're at risk of dropping out from their treatment program. So the most common flags that we've picked up, particularly in the MSK space, are difficulty with daily activities, whether they have indicators of chronic pain. So for example, if they've had their injury for longer than 3 months, and low quality of life as well, which taps into that social aspect of life that might be less obvious in a clinical treatment setting to start off with. And this number varies a lot between disciplines. So in podiatry, for example, we see this number is a little less. At around 40% of patients have at least one flag. And we see in physiotherapy, this number tends to be a little bit more. And so what we see is that treatment adherence can potentially be increased by measuring factors that we know from the research impacts recovery outcomes. And so taking a biopsychosocial approach and using this biopsychosocial model of care to take a holistic approach to patient-centered care is what we can potentially aim to do to solve this problem. So in terms of biological factors, we might measure things like injury duration, difficulty with activities, pain levels, and these factors tend to be assessed either in person in the clinical setting, or they can be measured using outcome measures, for example. And then we have the little less obvious factors, for example, social factors such as quality of life, a patient's living status, how often they might exercise, which may put them at risk or potentially improve their chances of recovering. And then finally, this last one here, the psychological aspect, which is probably the most difficult to gauge straight away in patients. And for this, there are many factors that could fall in here, particularly the patient's attitudes, their beliefs, particularly whether they believe that this treatment will actually work for them. Will this treatment actually be effective? Do I believe in actually going for physiotherapy, in going to chiro, in going to my service? Do I actually think that I will get better, or am I just doing it because someone's asked me to do it? And so we believe that measuring PROMs and PREMs that tap into those biopsychosocial factors can actually help us gain an insight into why patients might struggle to adhere to their treatment program. And so the goal really is to deliver better quality of care, to deliver value-based care and increase treatment adherence by using patient-reported outcome and experience measures to identify patient flags, to track patient progress, and to personalize treatment from day one. And what we see is that measuring PROMs and PREMs can provide key insights into patient behavior. And I touched on this at the start, behavior relating to not showing up for appointments, canceling appointments, for example. Can we use PROMs and PREMs to gain an early insight into patient behavior? And what would that workflow hypothetically look like, right? So as a step one, we could have a workflow where patients complete selected PROMs and PREMs that are sent from the practice, either pre-appointment or post-appointment, and patients complete this during their free time. And what will happen is we might bring this data in. We might have a platform that analyzes this data, automatically scores the data. Typically, we might have forms, for example, that we do now. We might have the DAS-21 that we do for a psychology appointment, or we might have other different questionnaires that we do as we go in, or we might have nothing so far implemented. Having a platform that can analyze this data, score it automatically, and put that information together in a really quick way that clinicians don't have to actually score things hands-on. So analyzing this data and then finally obtaining the data in a really easy to use format. So either through email or through a dashboard to really quickly understand what is going on with our patients and are there key risk factors that might put this person at risk of not completing their treatment program. So what could a potential workflow look like? So we could potentially use digital health technologies to track patient-reported outcome measures. And so what I have here is just a really quick mock-up, like a video, just to show you what that could look like. We might have our physio, this is an example physio survey, send out a survey post-appointment or pre-appointment to ask a few questions related to their experience and related to outcome measures. And so what this would look like is we'd get this information, have it on a dashboard. As you can really see really quickly in that color scheme, green could mean that the outcome is, we're going okay in terms of scoring now, and, amber and then red in terms of scores that fall below a threshold. So let's dive into that concept a little bit deeper. So what would hypothetically looking at outcome measures look like, and how do we interpret this information, and how do we use this information really quickly to take action? So this could be an example of an individual report of patient-reported outcomes. So this particular patient, if you can see here, has answered a few questions related to outcome measures. We see the patient-specific functional scale here that might ask a few questions on difficulty with daily activities, and we might get an aggregate score across any activities that this patient has mentioned. We're looking at quality of life. We might look at measures of belief in treatment efficacy, whether the treatment will work for them, their perceived overall health, and exercise frequency. And so what this dashboard tells me is that as a starting point at baseline, there's particular measures that we might need to pay attention for this particular patient. So if we look at the patient-specific functional scale, we can see the rating is really quite low. It's 4.5 out of 10, and this could put this patient at risk of not completing their program. And this is something we need to keep an eye out and focus on to get that functionality of that patient, that movement up for that particular activity. And as you can see here, there's a couple of these that have multiple bars in them, which means that we can measure outcomes of this patient over time. So we could see at baseline what their performance looked like, show them their improvement over 6 weeks, 12 weeks, etc., at the cadence that we think is reasonable. So that's at the individual level, but what does this look like if I wanted to understand how all my patients are doing at the aggregate level, or how can I understand how my entire practice is doing? So an example of an aggregate patient outcomes report could look like something like this. that has multiple different measures that you are measuring as part of your PROMS program and allows you to compare between measures. It might allow you to compare between different practitioners, between different clinic locations, if you're a multi-clinic location, and also different disciplines as well, if you're a multidisciplinary clinic. It might also allow you to draw comparisons between different age groups. Is there a difference in outcomes for some reason between our different age groups or genders? And so this provides a more holistic view of how the whole practice is performing on outcomes and can help clinicians take steps towards improving service and improving outcomes, but also shows a proof point for when the service is doing well. So that's an example in terms of outcomes. What could that look like in terms of experiences? The journey could be similar. The results could be similar as well. But typically with experience measures, we might send out a quick survey after their appointment. So typically these would be post-appointment and could be measured in the form of satisfaction with their appointment. It could be Net Promoter Score, so how likely they're willing to recommend the service to a friend or a colleague. It could also measure different specific aspects of Net Promoter Score, the experience as well. For example, breaking down the patient experience into the experience with their clinician, the experience with the staff, for example, with receptionist, experience of the timeliness of the session, were they actually seen on time, and then their experience of the overall environment. Was the environment clean, hygienic, was it warm and welcoming? And the important thing with experience measures is always having that qualitative feedback as well to go with the quantitative feedback that enables us to get this very rich insight into what the patient's experiencing and therefore take steps towards improving the experience for patients where it's been suboptimal. So this is all good and well to get all this information. What do we actually do with it, right? And how can we actually take action based on this feedback? So one of the ways that we can take action based on this feedback is to set thresholds for us for the clinic and for particular disciplines for each measure that will help us understand, okay, this is the level that I'm comfortable with. And beyond this level, for example, if a patient says that their experience was 8 out of 10 or below, this is when I want to intervene and then look at the reasons for why. And something that can be done with this is to automate some of that follow-up that can happen, right? Or automate the notification of that. So one of the things that we do is we alert all our clinicians every Monday morning for every patient who's completed the form the week before and let them know, look, these are the patients that you need to follow up this week, right? Let's get on to them this week and make sure they're okay. And what PROMS and PREMS allows us to do, and the most powerful thing it allows us to do, is this proactive engagement of patients. We don't wait for patients to fall through in their patient program. We don't wait for them to not show up or cancel their appointment. We have a mechanism, some mechanism to help us re-engage patients proactively and make sure they complete their program. Another question we get asked all the time is, we have PROMS and PREMS information. We know how the experience and the outcomes going on. How do we get a more holistic view of how our business is performing or how our practice is performing? And this is where combining the PROMS and PREMS information with analytics or clinical KPIs, for example, do not show rates or did not attend rates, our rebook rates, our patient visit averages, our revenue from patients, referral sources, etc., and being able to get a more holistic view of the practice health. And this is where combining the data from what the patient is saying and what the patient is experiencing with the actual metrics of the provider or the practice to do with how many new patients have attended the clinic, being able to forecast what that utilization of practitioners is in the clinic, being able to understand what the potential flow of patients would be, new patients versus existing patients in the future. And this is where we really think the power of data can really help transform healthcare businesses, is by combining both the patient voice with the metrics and the KPIs that we get from the business. So just to wrap up this part of my presentation, what I'd like to show you is some real life examples of the types of insights that we have gained from some of our customers that are using PROMs and PREMs. And some of these you may or may not be able to relate to, but what I'd love to show you is some actual feedback that we're seeing patients provide and what some of this data could actually look like in practice. So the client example I'm showing you here, I've de-identified that example. It's a client in the musculoskeletal health space. They're a multi-clinic location across Victoria, New South Wales, and Queensland. And so this particular client wanted to look at experience specifically. So they wanted to really get into what the patient is experiencing at all their different clinic locations, and are there certain clinic locations that potentially need to be uplifted in terms of the service that they're providing. I do love a good meme or GIF, so I decided to include some of these in tonight's presentation. This particular client has an 8.9 out of 10 average NPS score, which is great. They also have 81% of the base that we used here are likely to be promoters for the clinic. So out of their NPS questionnaire, which says how likely are you to recommend us to a friend or colleague, 81% are likely to have a 9 or a 10 in there, which is fantastic. An interesting insight that we gain for this group is that promoters actually tend to be in a very specific age group between 25 to 44 years, which could potentially provide an insight into the types of ideal clients that this clinic might want to attract to the clinic down the track as well. They have a top performing practitioner in terms of NPS scores and bringing patients back into the clinic. In terms of their perceptions of feeling cared for by their practitioner, their rating is pretty good. It's 9.1 out of 10. The average timeliness rating is not too bad as well. So it looks like clinicians are generally seeing their patients on time. And the reception staff are friendly. And finally, the cleanliness of the premises seems to be good too. So on an aggregate view overall across the clinics, it looks like they're doing pretty well. But when we look at some of the qualitative feedback, there does seem to be a few areas for improvement. And so there's specific areas that could potentially be looked into based on the qualitative responses of some of the feedback that patients are giving. And all of the feedback that I'm about to show you here is verbatim feedback directly from the patients that are completely de-identified. So for example, we have one patient saying, spend more time, they'd like more time spent on manual intervention. They're, not really happy with the amount of money that they have spent. Their perceived ROI is low in terms of this particular patient. Another feedback is more clarity on pricing and the pricing schedule. This particular clinic did have quite a bit of feedback on pricing and some inconsistencies in pricing that some of the patients had picked up. We do have a comment, while the general friendliness rating aggregate is quite high, we do see some locations that might say, look, we would like a more friendly reception. And this is interestingly a very common feedback we get on the small cup of water in the waiting room. We've had this feedback come through multiple times across many disciplines. So it's a very interesting one. Be honest and upfront in what you can do to assist me. So I think this comes back to clarifying treatment expectations, which is potentially a good feedback to share with the practitioner that this feedback came for. Having proper equipment, having more items that can be purchased from the clinic, which I think is an interesting insight for this particular clinic, because it can also give an indication of potential revenue opportunities for that clinic as well. Having more appointment times. And so this gives us an insight into a little bit of scheduling and providing a clearer explanation of their treatment plan. Again, coming back to clarifying treatment expectations and the patient-practitioner relationship here. So the qualitative feedback gives us a lot of rich insight when it comes to the patient experience measures that we'd like not to overlook in these cases. What are some other insights that are outside of the PROMs and PREM space that data can generally tell us? So we looked at some of those insights relevant to patient retention and experience, but now there's also insights that we can gain relevant to patient acquisition. So for example, for this particular client, we've seen that average revenue per patient is higher on Google than on Facebook, which could suggest that Google is probably a better advertising medium for them. We're seeing that, the top referred age bracket is 28 to 36 years. Again, an interesting and specific age range that this clinic seems to be attracting. They have certain suburbs that are generating more revenue, which could potentially provide some insight into if, for example, the practice wanted to expand. And then finally, there are patients who are referring this clinic even with no incentivization. So these patients are probably patients that we'd like to keep in and have as champions for the clinic as well. And so this is just a bit of a taster into what data can do for us and how data can be used in a way to improve the patient experience and also improve the business at the same time. And that's our mission at QuantCare. We want to bring the patient voice into practice, and having experienced that pain firsthand myself as a patient, this is something I'm extremely passionate about. So that's the end of my presentation now. Love to hear if you have any more questions when it comes to the Q&A part of this webinar. Thanks all.
Thanks, Rav. That was a great presentation. And yeah, we're going to have some Q&A at the end after our next speaker. So hold your questions and add them to the Q&A icon on Zoom so that we can ask your questions live. Thanks, Rav. And now I'd love to introduce our next presenter, which is Dr. Hassan Kadous. He wears many hats. Hassan, tonight he's presenting as the Director of Respiratory Rehab Australia. Hassan is a health professional who's passionate about the system change, transformation, and accessibility and equity to healthcare. He studied exercise physiology and physiotherapy at the Sydney University and has completed a doctorate of health business admin, focusing on the needs of culturally and linguistically diverse communities. Hassan has worked in a number of senior clinical, operational management and strategic foresight positions across local health districts, as well as the state. And he has a passion for future workforce models with a particular interest in clinical domains of emergency management, chronic care, particularly respiratory care, and aged care. And Hassan is highly motivated to increase timely access to healthcare services in a digitally enabled way in people's homes with a focus on enablement in FOLD communities. Thanks, Hassan. Over to you.
Look, thanks, John, and thank you very much to Lauren and the network for allowing me to present a little bit about the future of pulmonary rehabilitation in primary care. And we're focusing today on beyond delays, inconvenience, and traditional hospital centre-based barriers. I know it's been a long day for many of you who've worked a clinical shift and now are listening into this webinar, but I hope that you can lend me your ears over the next 15 to 20 minutes as we dive into some of the opportunities that really flowing after Dr. Ravi's presentation to improve patient outcomes and really see that great improvement in patient care. Just a little bit about myself, further to what John said previously. Really, this journey for me and the partners within Respiratory Rehab Australia started with a story of all of us kind of being impacted by someone who received care or received a poor level of care and unfortunately fell through the gaps of the system. A friend of ours who resulted in an unfortunate death, and that is the consequences that we're talking about here in the particular example, where if timely, convenient services aren't provided to patients, they do unfortunately deteriorate and suffer some really detrimental effects. I'm just going to quickly acknowledge that I'm on Wangal country. This was, is, and always will be Aboriginal land. The focus of today's presentation is to achieve 4 things. I want everyone to walk away empowered with the latest evidence that provides a compelling argument for the importance of pulmonary rehabilitation. I want us to be really educated on the benefits of pulmonary rehab and be mindful of those vulnerable communities that could be falling through the gaps. We need to place greater value on looking at alternate models for pulmonary rehabilitation, and at the end of this process, I hope that we can all learn about the opportunity to increase access to care for people with chronic lung conditions, especially in primary care, as this is a gap that currently exists. So let's start right at the beginning of the story. What's a little bit about COPD is going to be the focus around our chronic condition, a condition that has some significant burden on Australia, with 1 in 7 people over the age of 40 facing COPD, and it's has some real consequences on the health system where there can be some significant opportunities to avoid hospitalizations. Touching on those vulnerable communities, if you're an Indigenous Australia, you're 2.5 times more likely to have COPD than your non-Indigenous Australians. Now, the definitions are there for you in terms of diagnosis, but the focus of what you need to look out for as a primary care practitioner looking for those features of COPD is often your patients will present to you with some shortness of breath, some difficulty on exertion, might also feel a persistent cough or some increased sputum production, and you should be especially suspicious in clients that usually are over the age of 35, have a smoking history, but as well as that, having some breathlessness, some cough, and some sputum production. Now, what's the benefits of pulmonary rehabilitation? Well, there are some very well-established benefits through the literature that I've provided there from the bottom, at the bottom of the screen, but we can see that there's an improvement in the overall quality of life. There's an improvement and increase in functional exercise capacity. There's a reductions in symptoms of breathlessness and fatigue. Reduced hospital admissions is a significant thing that we see in the literature, as well as length of stay, and importantly, the reduction in those readmissions annually is a really important thing that we need to recognize, that there's some very clear evidence around the benefit of pulmonary rehab. It's important to recognize that these also translate into the economy and the health system, reducing those costs by having these very well-established pulmonary rehabilitation programs. Now, what's Hassan talking about when he's speaking about pulmonary rehab? From an evidence-based perspective, it's a structured program of 6 to 8 weeks of evidence-based exercise, and you can see this is direct from the Lung Foundation of Australia that provides that information for you, that definition, and it's really focused on an education program that helps people with their chronic lung condition manage their breathlessness and stay well and out of hospital. There needs to be an individualized assessment, which is focused in a safe environment, and really that there is a form of exercise and education that helps deliver this. There's a real focus on increasing physical function and making sure that it's tailored to the individual. And last but not least, there's an education component on managing breathing and energy conservation. Those, in a nutshell, are the crux of providing high quality pulmonary rehabilitation. So let's look at the current state. What does that tell us? Now, the Lung Foundation recently did an audit in 2022 to look at what the current state of pulmonary rehabilitation. And if anyone's one of those visual learners, you can see here that leaps out at you right on screen, that the fact that we have very low levels of private practice, non-hospital sectors providing pulmonary rehabilitations. The majority is sitting right at the top there in hospital-based programs. And I guess the challenge with that is the fact that the hospitals are often managing multiple staff across multiple domains, surge workforces, and that often can mean when we have all of our eggs in one basket delivering a certain type of delivery, there's an opportunity for the community there's a miss out for the community to actually be involved and receive those care services when the hospital has other priorities that it is perhaps focusing on. There's another snapshot there around who is referring, and the predominant patients that are being referred to pulmonary rehab come from GPs, specialists, or even self-referral. But you can see there's an underrepresentation of allied health professionals there that might be referring, or even nurses that might be with us today on the call that have an opportunity to really increase the referral rates to pulmonary rehabilitation. So, what are the current challenges in the story around pulmonary rehabilitation? And this is a very evidence-based approach. And I know there's quite a bit of text on screen, but I really want to break it up into 3 components. Number one, there's really limited availability of pulmonary rehab. And of the many people that could potentially benefit, they're not actually receiving it in an evidence-based manner. You have your average physio that would probably just apply a musculoskeletal framework to someone who needs COPD, and that probably isn't delivering the dosage that we spoke about as prescribed previously through the evidence. The second is that of the people who are receiving pulmonary rehabilitation, it's estimated that only 5 to 10% of those people are actually receiving the pulmonary rehab they deserve. And why is this reason? And this is why I want to really unpack with you all tonight, is that the evidence points to the fact that there's a lack of availability of local programs. We have issues with access and transport. We've got long waiting lists in established centres, centre-based hospital care, and we've got poor referral and poor consumer knowledge about the benefits of pulmonary rehab. The last point here is that we see a significant inequity in people who are from culturally and linguistically diverse communities unable to access appropriate care for pulmonary rehabilitation. So we're going to break down these issues a little bit more and maybe look at what some of the solutions that we all can play as a duty of care as health professionals to really advance the case of pulmonary rehabilitation for people with lung disease. Number one, that we actually have an image and a branding challenge for pulmonary rehabilitation. And I would say, as all of us here on the call today as health professionals, there's probably some misconceptions around a clear understanding of what pulmonary rehabilitation is, what it involves, and what's the benefit of the program. And I guess this misunderstanding translates into patients missing out on referrals and accessibility. The next item I wanted to break down is around the availability of data. So if you look at cancer services or other well-established sort of morbidity sort of measures, they would have some established data intake and data collection. Unfortunately, with COPD and pulmonary rehabilitation, we really struggle in this area. And I guess what you don't measure, you can't actually monitor. And that is a problem in its own right. Now, this is the one I really wanted to lean into. So the evidence points to the fact that there is an inequity in the availability of pulmonary rehabilitation around Australia from an accessibility perspective. And what we see is that there's a limited number of pulmonary rehabilitation programs, with transport being a key issue. You can imagine, put ourselves in a patient's sort of perspective. You have a significant lung condition. You struggle to get to the mailbox from breathlessness. You need to go to a centre to receive service. You've got to plan someone to have a day off to take you over there. Then you've got to look for parking. You've got to worry about the anxious walk up that hill to get to the hospital. That's a significant burden to put on someone who is a really vulnerable person within the community. As well as that, from an accessibility perspective, there isn't a one-size-fits-all approach when we are thinking about alternative models of pulmonary rehabilitation. So we're constantly stuck in that mindset, and we're not willing to use the available technologies that exist for us and do things differently in the way that we deliver pulmonary rehabilitation. We might have taken a slice or two during COVID and moved to those those virtual means, but by far and large, we've really gone back to just looking at our standard pulmonary rehabilitation process. And the last one that is probably most pertinent for us as a group working in primary care is that there's a lack of availability in the primary care settings, and that we need to think about innovating and developing these new seeds and programs, making pulmonary rehabilitation more accessible, particularly for consumers that are in rural and regional and remote locations, as a significant priority population. The final thing that I will touch on is, obviously, with chronic disease management and chronic populations, when you look at the data around people who have chronic lung disease, they're usually people from a lower socioeconomic backgrounds who've perhaps been through a long history of COPD and aren't well funded. And we're asking some of the communities most vulnerable and least well off to pay for an expensive service that exists out there. So there needs to be a bit of more of a lean-in from those administrative bodies who apply and offer grants to be able to offer these consumers and these patients care in the community. And I've seen recently some glimmers of hope. For example, the PHN over in southeastern New South Wales now opening the door to some grant opportunities specifically for these populations, because they are identified as vulnerable and needy groups, and funding sources for these particular groups are very challenging. So with all that said, why is this so important, and why is so much at stake? So the importance of this is reflected in the fact that we know that this issue actually costs us $615 million annually, based on the number of COPD presentations to hospital. For a rural person, it costs the health system $12,000 And for someone who is in a metro location, up to $9,700. And when you look at that, the cost reduction for each pulmonary rehab service that's been completed, it saves the system $10,620. So it is a viable product, and it's definitely, through a value proposition perspective, most worthy for investment. I think also it's important to reflect on the fact that there's, for rural and remote and very remote areas, there are 2.1 times more COPD deaths than when you're compared to those major cities. So we have, once again, a compounding factor for those people in rural and remote locations. So what do we want from you? We'd want your eyes, ears, hearts, and minds to increase the awareness around pulmonary rehabilitation and advocate for patients that need have COPD to receive pulmonary rehabilitation. We'd ask that you consider the alternate models, those non-traditional models. Move away from perhaps those centre-based models that have long waiting lists and have transport and access issues, and consider other options for patients so that they do not deteriorate waiting on those waiting lists. And last but not least, consider us as one of the providers, Respiratory Rehab Australia, to deliver timely, accessible care addressing some of those transport and access issues. On that point, who are we? We're a premium provider of in-home respiratory rehabilitation, physiotherapy, and exercise physiologist services to assess and treat patients with respiratory conditions. And now we're driven by purpose. We really see that there's a market gap here, and there's a gap for patients who need to access this. And this is where we think we can support the community at large to access these kinds of very much needed services. What can you expect? Well, you as a referring professional, as a GP, as a nurse, as an allied health professional, you would simply refer to us. We'd make sure that the patient would be seen in a timely manner through one of our respiratory therapists, through a physiotherapist or an exercise physiologist. The patient's assessed and prescribed a tailored exercise program, and they're in the own comfort of their home, whether it's through a virtual means or whether it's face-to-face. And the benefit of our service is that we reassess the exercise program, and we also make sure that we keep our specialists or our referrers informed as to the progress of our patients. So what does it actually look like as an example? So I'm going to give Mrs. V as an example. Mrs. V was referred to us on a Thursday. By Friday, we were seeing her. She came with a long history of COPD, worked at Woolies, and really COPD was starting to affect her everyday life, being able to put some of the items on the shelf. We took on Mrs. V, we completed a patient assessment, we assessed her quality of life, we had a look at her CAT score and her SF36, we did a functional assessment of her 6-minute walk time, we measured her shortness of breath, and we set some goals around what she needed to achieve in her life, focusing on what mattered to her the most. And for her, playing with her grandson was the most valuable thing. After we've completed that patient assessment, we move into that evidence-based exercise training model where we aim for 8 weeks to do the upper limb, the lower limb training, the strength training, and the flexible training, all tailored to the individualized need of Mrs. V. We then use a self-management approach to really create independence and support them with their airway clearance, their energy conservation, as well as that reinforcing that home exercise program and making sure that exercise is a fundamental way to complete their holistic well-being. Last but not least, we make sure we communicate effectively and come back to the referring professional, give them an update between their initial and final assessment, and make sure that we maintain that good rapport as part of the multidisciplinary team. And really, this is where we feel we are unique and specialized in this space and area. So you're probably wondering, what's it going to cost my patients? And because we are moving into patients' home, for a 60-minute assessment in the home in Sydney metro area, it's $190 for the 60 minutes of service, and that's where you can expect a high quality service with an initial assessment in the Sydney metro LGA area. For patients that need virtually online, for example, we're seeing patients interstate over the border and all around Australia, as well as people who are in rural and remote, we're charging $140 for 40 minutes, and that's Australia-wide. And you can see here we've had a great expansion around our availability in the Sydney metro region. So I guess to really bring it back to the key messages of what I've said today is that pulmonary rehabilitation really has some strong evidence around improving people's lives, their quality of life, their functional capacity, and it is incumbent on us from a duty of care perspective to make sure that we respect the rights of these patients and offer to them what is going to improve their quality of life. And I guess as a service, Respiratory Rehab Australia provides convenient, safe, risk-supported and empowering services that really tries to reduce fear, depression, and anxiety, and really promotes patient well-being and overall care. And how do you access the service as a referring professional? It's very easy, either to type in respiratoryrehab.com.au and refer your patient directly and refer them directly to our website. We can also get some flyers out to you without too much trouble wherever you are. Patients go in, they look at a suitable time according to all of our patient or all the available clinicians that can offer the service. We deliver the service to your patient and you receive some feedback directly on the patient's progress over time. If you'd like to send us a high quality referral as well, you're welcome to do that through admin@respiratoryrehab.com.au. And that's the main ways that we engage with our referrers. So thank you very much again, John, for the opportunity. I just want to acknowledge the great work of Lung Foundation Australia, and some of the data and the important literature that supported some of the discussion today has really been embedded and based in the National Pulmonary Rehabilitation Strategy. That's a great resource if you've missed out on that. And I'll finish there. Thanks very much, John.
Thanks, Hassan. That was a great presentation. I really appreciate the time you spent with explaining COPD and the options available, particularly in primary care. Just to everyone attending, so thank you, Hassan. For everyone attending, we've got some Q&A time now, about 10 minutes or so for questions to our presenters. If you could just pop them straight down into the Q&A button on Zoom, and we can get to your questions. Looking forward to some questions from our attendees. I might get the ball rolling, actually. So Hassan, just in terms of, just because your presentation is fresh in my mind at the moment, in terms of the particular barriers you get from maybe some of the patients that your group attends to, are there particular exercises that are a bit more difficult for some than others? And what are the barriers to people actually improving under your care of the period of, say, 6 to 8 weeks?
Yeah, it's a good question, John. I think first and foremost, so I'll break your question into two parts. One was some of the challenges that they face with exercise. I think a common one that we do get from our patients is the fact that a lot of the upper limb exercises that they do go to complete, it also depends on the same muscles that are responsible for breathing. So they really struggle with some of those upper limb exercises because your muscles that also support breathing are the muscles that you're training through an upper limb program. So that's some of the challenges. Obviously, motivation and chronic pain and prioritizing some of the exercises in a world of busyness for some of our patients is one of the complexities. The second item, I think, John, that you asked about was overall the care that we deliver. If I can go back to the question, John, you mentioned the difficulty that they have with exercise. The barriers that we face is really a focus on some of the funding and the ability to fund some of the services. So where someone has an aged care home care package, that for us, if you're a clinician that has someone who has that aged care package, it really does support them receiving the care for the 6 to 8 weeks because it's a fully funded program. Where people struggle is where they might not have private health insurance, obviously, and then the other point is where they've perhaps exhausted some of the EPC program or the CDM program that's freely available through Medicare through the 5 sessions. So those are some of the challenges and barriers that we find in sort of service delivery. John, to answer your question.
Thanks, Hassan. I've got a question just for Rav. Just in regards to PROMs and PREMs, we understand that they're really important for patient care, patient outcomes, treatment effectiveness, and monitoring patient compliance to a degree as well. We know that GPs have fairly well ingrained PROMs in their practice and at an aggregate level that can be measured and compared between practices and areas and regions and states. Hospitals to a degree also have their PROMs and PREMs emerging to a degree where it's interoperable and shareable. when it comes to allied health, we know that the research tells us that allied health do measure PROMs and PREMs, but there's a lack of centralized ability to actually gather that data. How do you feel quant care is going to help with that? And I suppose, what's the trajectory moving forward in terms of the uptake? How willing are allied health to take up PROMs and PREMs in a more structured way that gives more data?
That's a really good question, John, and I think speaks to I guess where the industry is heading as well, right? So where we'd like allied health to go down the track. So in terms of answering that question, I'll first touch on the point that's related to how do we actually make this easy for people to use. And I think that's the key challenge that I see if we look at a barrier to uptake potentially is how much effort would it be for our allied health clinicians, right, in terms of uptake to actually implement something like this. And then secondly, what does this mean for patients as well, right, in terms of, as I think Hassan touched on as well, in terms of that motivation, the patients who might have chronic pain might have difficulty actually getting through the program. And on top of that, we're having an additional ask from them as well, right? So from those 2 points of view, I think to increase uptake in the allied health space, the first thing we see is that interoperability with the patient management system or with systems that allied health clinicians already use, right? Because from a behavior change perspective, right, or a habit building perspective, having to use multiple different systems, having to log on to multiple electronic health record systems is not ideal for clinicians in general, right? So allied health and others as well. So I think the key step is looking at systems that we already have in place. So what are allied health clinicians already using? What are the patient management systems or the practice management systems or the EMRs that we're currently using? And let's try and build solutions around those that fit into those, that can pull data into those systems, pull data out of those systems when required, as opposed to having completely different systems that we now need to train and retrain allied health clinicians on. And that's a core principle that QuantCare has focused on as well, is what are we actually already using that we can then use to plug into and provide that information direct to the clinician's fingertips without asking for an extra effort from them to be able to use this. So reducing the barriers as much as possible to entry, I think, is where we need to go if we want to increase the uptake of PROMs and PREMs in the allied healthcare space. And that's the first thing for clinicians that I see is how much can we automate and how much can we make this easy to use. And then secondly, for patients as well, right? How do we explain the importance of PROMs and PREMs and why we're asking patients to do this for us? How can we demonstrate the value of PROMs and PREMs to our patients to encourage that completion, to get that completion rate from them and encourage them to provide this information to us in a way that's usable and demonstrate, look, this is where you were when you started, this is where you are now, and this is why we want you to give this information to us, right? We want to show you that you are getting better. And can we use that information to motivate patients on their recovery journey as well? So I'm optimistic, John. I think about the future. I think if we look 5 years ago where Australia was in the digital healthcare landscape and post-COVID where we are now, I do think obviously we do have some way to go compared to the US and compared to Europe, for example. But I do think we are, as a country and as a community, making more steps towards becoming more open to adopting PROMs and PREMs and digital health technologies in general here.
Thanks, Brad. Thanks for that. Got a question for Hassan from Roger. Roger's asking, do you run exercise sessions, Hassan?
So in terms of group exercises, the way that I'm interpreting it from Roger, so we do have an established program over at Marrickville that is a group exercise session. We're currently in a bit of a partnership with a study over at Sydney University as part of that group exercise program, but it's also open to the public. So that's the main hub, but we will be opening some increasing hubs. We're just trying to invite them in community centres. Our main point is that we want it to be accessible and we want the parking and the availability to be quite easy, because we've understood that that's quite a challenge for the community. So selecting the right site to make sure that that is a matter of ease for our patients is most important. So yeah, we do run the group sessions. It's also available on our website. If you just want to, I think the QR code is up there now. If you jump on there, there's an opportunity to link into that group exercise program.
That's great, Hassan. Just a question actually on the groups. Do you run groups virtually as well?
We really find that the maintenance side of things is where you someone who's completed those sessions, the face-to-face, they've gone through that process, that supervision, that motivation, that encouragement, that safe and risk awareness. That's the first stage. Once they've completed, they're offered an opportunity to go into either one-on-one maintenance. And for some of those clients that I mentioned earlier that have the aged care packages, they enjoy that, and that's something that they do for lifelong health. For others, we do offer sort of a grouped sort of booking where you can come in with a group and just it's more of a support network for those people that are sharing, and we obviously remind them about those exercises and those breathlessness sort of management techniques and everything else. So yeah, we do have a few bespoke options once people complete their program, but the ideal and the evidence says that a supervised program to start off with for the first 8 weeks is what's needed, and then you can wean them off into a bit of a maintenance program to follow.
That's great, Hassan. Yeah, I'm still remembering that slide you had up there of most people attending hospital. I think it was 84% attending hospital for COPD and pulmonary rehabilitation, with a very small amount going to through primary care. I'd really love to see, data over the next 30 years, just to hopefully see that bar of accessibility to pulmonary rehabilitation grow in primary care to the same levels as hospital care, but also to see how people's lives are improved in terms of their quality of life, length of life, just because of this initiative.
Yeah, look, John, as Rav said, that optimism and that hope is definitely there for us. But I think it goes without saying that if the necessary investments aren't made in primary care, so you've got a workforce planning opportunity there to make sure that you have the right workforce. You've got to make sure that that seed funding to make sure that these programs can exist and are well developed, exist out there for those benefits to flow on the community. And I think you can see from a value proposition model, so some of the work that Lung Foundation has put forward is absolutely phenomenal. To think that we can save, a significant number of hospital presentations, keep people out of hospital, keep them healthy, especially the volume of numbers of people who get exacerbation of COPD in some of the cold and winter months. And I know just before we were jumping into the session, Ravi and Ravini and I were comparing how cold it was in Melbourne compared to Sydney. And this is a period of worry for many patients with COPD. It's a period of peak presentations to hospital. And as we know, hospital avoidance is we wouldn't want our family members to go in there and perhaps catch something that would be a negative effect of a hospital presentation. So hospital avoidance is the focus of a lot of what we do, and we think it'll improve patient outcomes over 10, 15, 20, 30 years, John. And we just need the sort of investment there from the primary care sector to make that happen.
Oh, that's very promising. Thanks, Hassan. We've got one last question. Rav, just a question in regards to not overwhelming practitioners, our allied health clinicians in practice. How can we make collection of PROMs and PREMs easier and possibly automated, so that really what we're looking at on a day-to-day basis is actually how are our patients doing, where do I need to focus on, which conversations do I need to have, rather than actually having to pull our papers out and figure it all out for ourselves? Is there a way of automating it?
Absolutely, John. And there's a few aspects of the journey that can be automated as well, I think, to make things easier for our clinicians. And I think the main way, I guess, to start doing that is looking at which PROMs and PREMs are actually relevant to the particular practice, right? We might work together with certain team members in the practice and we decide on, look, these are the top 5, 6, 7, whichever many PROMs and PREMs we want to assess, and which patient groups we want to send these PROMs and PREMs to. And I think once that's been decided, what we'll do is we'll say, look, these are the measures that are going out to the patients, and let's do it digitally, right? Let's not have our paper collection, our forms that then the clinicians have to go back, or a practice manager has to go back and transcribe manually onto a system. Let's collect these measures digitally now that we have them, and then give patients a heads up when they come in for their appointment that they have this coming through, and this is why we need this information to help personalize their treatment and track their progress over time. So firstly, automating, I think that survey creation and generation is step one. And then we know that practitioners basically don't have that effort of having to manually administer those surveys or create the surveys themselves. So that would be the first step for me. And then the second step really is about how do we now automate the data analysis and the results for the clinicians, right? So we're getting the survey out, that's great, it's automated. How can the clinician get the information back, as you say, John, in a way that's easy for them to interpret, and they know exactly what we need to do? And this part to me is where technology can be really powerful if it's used correctly, is, for example, setting up alerts, right? So when we have patients that fall below a certain threshold on any of those scores, we can automatically alert practitioners to let them know, look, you saw John last week, he's actually fallen below the threshold on this particular measure. Why don't you try following them up, right? And this is if for example, you've given a qualitative response as well, say a response saying, you're feeling X way, or you have some feedback about the service, that's even more incentive to follow up as well. So to me, that's the second part, John, on taking that action, right? Let's automate the part where clinicians get notified. They know exactly which patients might require following up, and this will help them take steps to do that without ever having to manually log on to anything or understand, try and work out what has gone on with those patients. So back to that concept of proactive re-engagement, but keeping it simple so that clinicians know who to follow up and why they are following up that patient.
That makes a lot of sense, right? And thankful that there's a system like yours available to Allied Health to collect all these measures. We don't have any more questions. I'd like to wrap it up. I'd like to say thanks to both Doctors Rav and Hassan today for your valuable time and for sharing this wisdom in regards to data collection, proms and prams, and rehabilitation of the lungs, pulmonary rehabilitation. It's so good to see high quality allied health clinicians sharing their goodness, which is really what CESAHN is all about, the Central and Allied Health Network, Central and Eastern Sydney Allied Health Network. Our network is about supporting allied health clinicians in primary care. It's about bringing clinicians just like yourselves, Hassan and Rav, to highlight the benefits of the programs that you provide, but also just to highlight that Allied Health are doing a really great job in our region and across Australia, actually across the world. It's lovely to see. So thank you both. Thank you both for your time.